We talk about heart attacks sometimes happening after stress, after, exertion, or completely out of the blue. So it's not always something we can predict, but the physiology is that vessel kind of plaque ruptures.
Hello and welcome to another episode of Uplift for Her. I am your host, Dr. Mallory Craycroft, and we are here talking all things women's health. And we have a really great conversation today that hopefully will be really helpful. We're talking about heart health in women and cardiovascular disease. So we have a special guest, Dr. Tanya Wilcox. Dr. Tanya Wilcox completed her medical education at the University of California, Irvine, following her undergraduate degree in evolutionary biology at Princeton. She continued her medical training with a residency and chief residency in internal medicine with a fellowship in cardiovascular disease at NYU, at New York University. Dr. Wilcox is a general cardiologist with clinical expertise in preventative cardiology, lipidology, disorders of metabolism, and echocardiography. Her academic interests include investigating the association between metabolic risk factors in cardiovascular disease and perioperative cardiovascular outcomes. So thank you, Dr. Wilcox, for being here.
Thanks for having me. I'm excited.
I think you're going to agree with me on this, but talking about heart disease in women is a really important topic.
Of course.
Will you just start us off by telling us why?
Yeah, so heart disease is the leading cause of death in women. And I think we haven't traditionally talked about it enough. We traditionally think about heart disease as a male predominant kind of pathology, and that's not the case. And so it's really important that women recognize that they need to take care of their hearts.
Yeah, just some statistics I found. So correct me if these don't sound right to you, but 1 in 3 women die of a heart attack. That's somewhat baffling to me because I just don't think we think about that. Like, I don't know that anyone would guess that statistic. I also found a statistic that there's actually more women who die of heart attacks than men. Does that sound right to you?
Yeah, definitely that, 1 in 3 women will die of heart disease, which is, a astounding statistic. But it is kind of a really common disease in humans overall.
Yes, yes.
And so that's why it's so important that we kind of talk about prevention and risk factors.
For sure. One thing that I just wanted to kind of start off the conversation with is, why don't we hear about this more? I mean, 1 in 3 women are dying of it. I feel like women hear a lot about breast cancer prevention and right now a lot about menopause. I don't know that I think we all see the red come out on the heart health months, right? But why don't we see this more in women that we know who've had a heart attack or seen that in people that we know?
Yeah, well, I think it took a lot for kind of advocacy groups to get people talking about breast cancer. And I think we're just a little bit behind on heart health.
Yeah, that's a good point.
But there's great advocacy groups like the AHA and the Go Red kind of campaign that are kind of taking some lessons learned from the community that helped us get awareness about breast cancer.
So just a lot of marketing, basically.
Yeah. And I think that's huge. But also there's a tradition in kind of old school teaching in medicine that it is a male predominant disease, which is not the case anymore. And then, unfortunately, because of a lot of lifestyle factors that often we, as a society in America don't have a ton of control over, heart disease in general is just increasing. We have chaotic lives, we have sedentary lives, we don't have access to great food and exercise. And so for all those reasons, I think it typically was thought of as male, but it's just not the case.
Yeah. Let's talk a little bit. I don't want this to be a downer episode. I think there's a lot we can do to decrease risk and to prevent, but a lot of that starts with education and empowering women to advocate for themselves and to know if it might be an issue for them. So this may seem like it's focused on a lot of things like risk factors and negativity, but I hope people feel very empowered about it. I don't want this just to be like we're all cursed, like this is a terrible situation. I think there's so much good that can be done.
Yes.
But to start with, let's just talk about a couple of the things that come up in our medical system that may be a little bit complicit in maybe not preventing as much heart disease as we can. I think for women especially, there are some biases that don't do us any favors. I think as an OBGYN, one of the things that we see is I am the main point of care for women oftentimes from about 18 to 45. I'm the main person that they see. And I get almost zero training in lipidology and in cardiovascular health and in screening. That seems to be a bit of the problem. Are there any other thoughts you have about that or other things that you see in the conventional medical system that maybe we could do a little bit better to help women identify and prevent heart disease sooner?
Yeah. Well, I think, early in adolescence and kind of early adulthood, people should be screened for metabolic problems like high cholesterol, so a lipid panel, and diabetes, so an A1C. But I think specific to women, that a lot of providers might be a little bit wary of starting preventative medications early on in a woman's life because of reproductive potential. Right. And they might even be uncomfortable having the conversation about a woman's desires about reproductive potential because we're rushed.
Yes.
And it feels like maybe that's not relevant to them. But I think that's a huge structural kind of barrier to women getting maybe preventative medications or kind of more aggressive interventions because of the presumption that pregnancy might occur. And that may or may not be the case for different women. And it just creates a kind of big time lapse between the typical preventative care that a man of the same age might get.
Yeah. I think that's really true. I think there's a large number of women who don't get screened for metabolic risk or cardiovascular disease, even when they're going to the doctor. And some of that, I think, is because it's not even in the doctor. It's not hammered into doctors enough that this is a really big problem. And so I think we see people in my position, we'll see people who are 20, 25, maybe 30. The top thing on our brain is not, I should make sure her cholesterol is okay. I don't even think it's usually, I should make sure her blood pressure is okay. We hit that hard in pregnancy. Like we will check your blood pressure every time we see you. And if we can, every time we talk to you on the phone, right? Like we want to know your blood pressure in pregnancy. But outside of pregnancy, I think that even blood pressure kind of is like, oh, your blood pressure is a little borderline. Make sure you follow that. Or, oh, your cholesterol is a little bit high. You should probably diet and exercise. We'll see you in a year.
Yeah. And I think transitions of care is an interesting place to start also with, say you identify a woman during their pregnancy who does have high blood pressure, preeclampsia, or gestational diabetes, and then they're no longer pregnant. They may not see you anymore. That's a great opportunity to transition care to a preventative cardiologist or a primary care doctor who's kind of aware that these are really important risk factors for future disease. And this is someone you should take seriously and engage in kind of different preventative strategies. So that, I think, transitions of care are really hard in medicine, as patients and doctors know. And so that's just a structural thing that we could get better at.
Yeah. Okay. Well, let's back up a little bit and talk just through some definitions.
Sure.
So I think when we talk about cardiovascular disease, cardiovascular risk, heart disease, will you just define that and make sure that we're all on the same page with it?
So cardiovascular disease is very broad. When we're talking about the most kind of common forms and the forms that cause heart attacks, the kind of typical heart attack is caused by a blockage of the arteries that supply the heart. And usually that blockage is from cholesterol plaque building up in those arteries. Mm-hmm. Arteries that supply the heart are really, really small, and even a little bit of plaque can cause issues. So that's a traditional heart attack. However, it is important to point out that there's kind of female-specific disease states that cause heart attacks that aren't related to cholesterol. They're just much more rare. And I think we might even do a disservice to kind of underestimate the amount that this kind of traditional atherosclerosis is contributing to heart disease in women. Because I do want to mention, things like inflammatory states or dissections, kind of more unusual forms of heart attacks do exist. But primarily the cause of heart attacks is cholesterol buildup into those arteries, which is due to a few risk factors that we can kind of go over. Family history is a huge one. Mm-hmm. High cholesterol. Makes sense. Mm-hmm. Overall inflammation in the body is a big one. And then diabetes. And then, of course, high blood pressure and smoking.
Okay. And
sedentary lifestyle. Mm-hmm. And so that always seems like a scary, big, long list. But the positive part of that list is a lot of them are modifiable. Mm-hmm. And so that's why prevention's a great kind of space to be in, because you can counsel people how to reduce their risk.
So as we're talking about some of the nuts and bolts of this, just so people understand what actually is happening in the biology, I think it's helpful to kind of visualize it. So in the heart is made up of muscle, right? Mm-hmm. So it's a pumper, and the muscle is supplied by blood vessels.
Yes.
So those are the vessels we care so much about. We think of our blood vessels that are going in and out of the heart, the vessels that are like supplying the rest of our body. Those are important too.
Yeah.
But these little small ones, they're just the ones that are supplying the muscle of the heart. And so if those guys get clots in them, then the muscle doesn't get blood flow and that piece of muscle dies. And you need all the pieces of your heart muscle. Yep. You want all of them to be pumping and working in conjunction. And so if you get a blockage, even in one tiny blood vessel, that cuts off supply to a piece of muscle, that muscle dies. Now you have a little part of your heart that is not effectively pumping blood.
Yep.
Did I explain that okay?
Perfect.
So what causes those clots, how often is it a blood clot? Like people, especially women, know about pregnancy, blood clots in our legs.
Yeah.
How much does that type of clot play a role here? Is that a role at all, or are we only talking about atherosclerotic plaques?
It's more rare that it's a, blood clot that would come from the venous side. So blood clots that form in the veins, during pregnancy, or perhaps because there's a malignancy or a hypercoagulable state, those should be filtered through the lungs. And so it's hard for those to get into the side of the heart that's supplying the blood. But if you have certain conditions or like atrial fibrillation or a hole in the heart, that can happen. It's just much more rare. The more common form of clot that forms in the heart is due to that cholesterol, plaque, and platelets that come to that plaque. And we talk about, plaque is usually, a cholesterol buildup in the wall of the artery, and it's staying there. And our goal is, once it's there, is to stabilize it and prevent it from getting bigger and rupturing. And then once it ruptures, that's a heart attack. And that's when the blockage completely stops blood flow to the heart, like you were talking about, and can cause problems with what we call ischemia.
Okay. So backing up and reiterating that in less fancy terms, because it's perfect. So you start with a cholesterol molecule. It's just a little guy moving around the blood. Totally benign, correct? Nothing wrong with the cholesterol molecule itself. So when we look at our LDL and our total cholesterol and our HDL, those are all different types of these cholesterol molecules, all of which are neutral to start with.
Yeah.
What happens to those molecules then to become a plaque? And also, the plaque is, I visualize like a speed bump, right?
Yeah.
So you've got these nice smooth walls of the artery, and then you've got a big speed bump. And the bigger that speed bump gets, the more narrow you have the blood actually flowing through. We don't like that. But especially if that plaque, that speed bump explodes and ruptures its contents, then those contents flow down into the narrowest part of the vessel and will completely occlude, will completely shut off the blood flow, right?
Exactly. And this is where, your question is, why does cholesterol go from kind of a neutral building block in our body to something that's
a problem?
Pathologic. And so inflammation is where this really comes in. So those smooth blood vessel walls should not let cholesterol into them. But if there's damage in the walls, or there's kind of particularly high levels of cholesterol or certain types of cholesterol, they kind of weasel their way into the wall. And then your body doesn't like when they're there. And your body's response is to go and send the immune system to go kind of wall it off and take care of that. Usually chew up that cholesterol, try to kind of neutralize it. But when that process happens over and over, they can get bigger to the point where they're called unstable. And that's when we worry about them rupturing and causing acute disease. When they're stable, you can still have some symptoms, but those symptoms can often be managed or should be managed with medications. So kind of stable versus unstable heart disease. But often what triggers kind of an acute event is a change in the blood vessel wall and the inflammatory state. So, we talk about heart attacks sometimes happening after stress, after, exertion, or completely out of the blue. So it's not always something we can predict, but the physiology is that vessel kind of plaque ruptures.
And what causes that vessel wall to be vulnerable to begin with? What are the things that affect the vessel wall? Because if the cholesterol stays neutral, well, you mentioned an exception to that, but assuming the cholesterol is just a neutral guy running through the blood, what causes the vessel wall to be vulnerable to begin with?
Yeah. Back to those risk factors. So smoking is a huge one. It's really damaging to your arterial wall.
And in all of your organs.
Yes, in all of your organs. Yes. Exactly.
So don't smoke.
Yes. Diabetes is similar. So blood sugar running around kind of unchecked in the blood is bad for the blood vessel wall. What's good for the wall? Exercise. Low inflammation states. So exercise does a great job of decreasing your systemic inflammation. High inflammatory states, so uncontrolled and autoimmune diseases, things like that, damage the vessel wall. So
okay. Yeah. So we'll see increased cardiovascular disease in any of those more inflammatory states. So getting inflammation down overall is important. And then if the cholesterol does find a rent in the wall, a vulnerability in the wall, then it's going to, partially because of the immune system, and then the cholesterol gets into that rent and starts to build the speed bump. Is that right?
Yeah, exactly.
And if that area then is exposed to inflammation, then it becomes more of this snowball effect.
Yeah.
Correct. Okay. Now, what causes those plaques to rupture?
But sometimes it's just random. So they just get big enough that they, kind of the inflammatory balance of keeping them under control fails. And then, and so we have a lot of preventative measures, what we call stabilized plaques with medications, supervised exercise, things like that. And then occasionally it'll be like an inflammatory state. We do see some signal that there's more MIs during, acute episodes of like influenza, which is really
meaning heart attack.
Yeah. Yeah. Sorry. Thank
That's
you.
good.
Of heart attacks, acute heart attacks during things like influenza pandemics and things like that. So the other thing I'll say that's kind of more specific to women when we're talking about, really vascular biology here is that, your blood vessels, we call them the coronaries because they're like a crown that goes over your heart.
Those are the arteries that supply the muscle.
Yeah, the arteries that supply the muscle, the coronary arteries. The three big ones are the ones we pay a lot of attention to, but they all kind of go into smaller and smaller and smaller vessels. And we call those like the microvasculature. And it's common for, both sexes, but women more commonly can have disorders of actually those even smaller blood vessels. So then we can look at the bigger blood vessels and we don't see too many speed bumps, but there's still something going on. And so we're getting better at testing for those smaller vessels and seeing if there's actually dysfunction in those vessels causing the kind of typical symptoms we see with typical heart disease. And so that's something called microvascular angina. And
meaning pain in the chest.
Meaning pain in the chest. Yeah. And that's something that was probably ignored in women for a long time. There's also kind of other more common forms of chest pain that, again, we would look for speed bumps. We wouldn't see them. There's something called spasm where the vessel clamps down and then releases and it causes chest pain. And those are things that, again, we ignored because we focused a lot on this one kind of physiology that's more common in men. And so those are things that, if you're having a lot of chest pain and we look for the speed bumps, we don't see them, seeking out a specialist who understands kind of some of the more nuanced things that can be going on in the arteries can be really helpful.
And I would add to that, taking all of those preventative steps, even if you don't yet have the diagnosis, like for sure seek out the specialist, but also those preventative steps are the same things we do to prevent all disease, you know, so seeking out exercise and anti-inflammatory foods and anti-inflammatory behaviors, I think is still the way that we should go. Yeah. So one of the things we hear associated with heart disease a lot is blood pressure. What does blood pressure have to do with any of this?
So when the pressure in those vessels, so when we measure blood pressure, right, we squeeze your arm and we get that big brachial artery and we use a cuff to figure out how much pressure that artery is actually feeling. And the two components kind of that contribute to blood pressure are how stiff that artery wall is and then how much fluid there is in the body overall. When there's a lot of pressure on those arteries over time, it causes damage like we were talking about. So just, that damage in that vessel wall that allows those pesky little cholesterol molecules to get where they shouldn't be. It's important to emphasize that blood pressure, it's a silent problem. And so you won't know you have high blood pressure unless you're going to the doctor and being checked. And that's why it's, the paramount of
a
screening.
Vital sign.
Yeah, it's a vital sign and it's really important to screen. It's also important to know that an individual high blood pressure reading is not necessarily harmful. That could just be a physiologic response. It's that a chronically high blood pressure is the problem. And so our bodies are meant to have varying degrees of blood pressure depending on what's going on.
You mentioned that one of the reasons that the blood pressure is such an issue is that the blood pressure is a sign that the artery walls have become non-compliant. They become more stiff. I think of like old garden hoses and they become really brittle and not great.
Perfect way to say it, yeah.
What causes that compliance to get worse?
Yeah, so a lot of blood pressure is genetic. So some people are just prone to get higher blood pressure when they're younger. A lot of it has to do with age. Most as we age. So the combination of age and your genetics means that some people, you could do everything right and your blood pressure is still going to be high. So don't be hard on yourself if this happens. But the same metabolic risk factors also contribute to high blood pressure. So things like obesity and smoking, sedentary lifestyle. Another big one that is important to think about too is sleep apnea. So if you're, not getting enough oxygen during the night when you're sleeping, that causes high blood pressure as well.
So some of the main things we've identified so far that we really want as women and as humans, but we say women here, one of the things that we really want to make sure is that we keep those blood vessels compliant as much as we can. So the things that you mentioned, we also want to keep inflammation down, which is a topic in and of itself. But for right now, for those purposes, really living a lifestyle as much as we can from a lifestyle perspective of decreasing inflammation is going to help those cholesterol particles be more neutral and the vessel walls be more healthy and keep this from becoming that snowball effect that is problematic. Talk to us a little bit about, you mentioned blood sugar. How does blood sugar play a role in all of this? We all kind of know that like diabetes and blood sugar is somewhere thrown in there with heart disease. What's the connection there?
Yeah, so it's specifically that when the sugar is high in the blood, it's super damaging to the blood vessels, both the large and the small blood vessels. And that's all over the body. And so that's why, if you have diabetes, we need people to check their eyes because those tiny vessels in your eyes can be affected. And it just breaks down that, what we call the endothelial lining. So it's just the lining of the blood vessel that's kind of keeping the blood cells where they're supposed to be, gets damaged directly by the blood sugar, and kind of the blood cells themselves actually kind of get extra blood sugar tagged onto them. And so that's directly damaging to large blood vessels, small blood vessels, kidney blood vessels, nerve blood vessels. So diabetes overall is something that we really need to take control of, and is a very large metabolic risk factor. And then the kind of subsequent inflammatory issues that go along with diabetes, I think, are a little more nuanced, but yeah.
Yeah, but like you mentioned earlier, the blood sugar can damage the lining of the wall and also worsen the plaques, right? It also causes that inflammatory cascade of the plaque itself, decreasing the stability, like you mentioned.
Yeah.
Okay, so we know blood sugar is a problem. So we also want to have the lifestyle that promotes a healthy blood sugar. We talk about cardiovascular disease as the heart. Talk to us about how the blood vessels, just briefly, because it's a little bit off topic, but I think it's important to mention how blood vessel disease affects our other organ systems.
So I think I kind of divide in my head when I'm thinking about blood vessels, large and small. And so when it comes to the larger blood vessels, obviously, the blood vessels that supply the brain can also get speed bumps and can cause strokes. So that's a big problem. The larger blood vessels that go to the leg you can end up having problems supplying the muscles in the legs. And so then you get, something called claudication, which is kind of cramping in the legs as you exercise, and problems with wound healing. And then when it comes to the smaller vessels, that's when I think about things like the kidneys. The kidneys filter all of your blood constantly. And so they need all of these kind of little filtration systems that are lined with this lining that we really want to protect. And so whenever we're damaging our blood vessels, that's thereby damaging the kidneys. And the brain also has tons and tons of all these little networks of tiny, tiny blood vessels that we want to protect. And so if we're damaging the blood vessels anywhere, we're also going to have problems with the blood vessel integrity in the brain.
Thank you. I bring that up because it's sometimes in medicine, we kind of segregate the organ systems and we kind of think about this over here and this over here, but really it's all one disease state, and it's all, if it's affecting the heart, it's also affecting the other organ systems. And so some people it will actually manifest differently. Some people it may manifest in the kidneys before manifesting in the heart, but it's still it's still going to be a big issue for the heart, and important just to remember the body's one body.
Yeah, I think that's super important to underline when it comes to treating heart disease, though, because I think all of us, want, if we find out we have a medical problem, a quick fix. So especially say, you do unfortunately have a heart attack and you get a stent. The problem isn't fixed. So I get the question all the time in my clinic, when I'm prescribing medications for the heart. So when can I stop this? How long do I have to take it? And the answer is, this is your new, morning vitamin. You need to take this forever because, we've established that your body has kind of an unhealthy inflammatory metabolic situation, and we can fix it in a bunch of different ways. And maybe very aggressive lifestyle over a long period of time, we could think about pulling things back. But generally, once we need to treat a risk factor for heart disease, I tend to just keep the treatment on as long as they're low risk and the patient's tolerating it, because it's a systemic problem. So just because we fix that one speed bump in the heart does not mean that you might not face problems later on in the legs, in the brain, if we don't go ahead and treat everything aggressively in the whole body.
So tell us, first of all, is this disease state that you're talking about with these plaques, is this a rapid process or a slow process? Is this like a year or 30 years? When is this starting and then becoming a problem?
Yeah, and this is where I'm afraid to freak people up. It starts really early in all of our lives. It's kind of just a consequence of being a human that these plaques will develop at some point in our lives. But we have kind of the earliest data we have on this is from autopsy studies from young men who died in wars, and they do have plaques forming in their aortas and their arteries in their 20s.
Yeah.
So they're there, but the fact that they are there doesn't mean they're going to cause problems. But it just emphasizes that, everybody should kind of adopt these healthy measures because we're all at risk. Some people are at much higher risk than others, and we can talk about who those people are.
Yeah. I think on the flip side of that, though, we can see, you see that in that age group, but bodies are pretty resilient. I think what we see when we get to major disease states in the body will age, right? The body will go through changes where certain functions aren't working like they used to. And we can do lots of things to slow aging or to minimize aging. And there's fun stuff that a lot of scientists are doing, looking at anti-aging, and that's all wonderful. But even as we age, the body can tolerate a lot of change. It's when you get one thing piled on top of another. Yeah. And so as you get a lot of these risk factors together is really where we see the worst outcomes, correct?
Yeah.
I mean, if you take someone who has multiple risk factors like a family history, and they're a smoker, and they're overweight or have struggled with being obese for most of their lives, that's going to be a harder situation than someone who's doing most things pretty well. They're going to have a much lower risk because our bodies are so resilient.
Yeah, absolutely. That's why I think a lot of our risk scores, or when you kind of see a doctor in clinic, they'll ask you a whole lot of questions about kind of, your family history, kind of, especially when we talk to women. I think we need to focus more on, when their menarche was, and if they've had complications in pregnancy. So all these things that you think might not be related that your doctor's kind of hounding on are actually really important. And you want your doctor to be asking all those questions to get a better sense of your overall risk.
Yeah.
And that's why, certain risk scores that we'll use are helpful. And then I think also definitions, like the definition of metabolic syndrome is nice because it takes into account a lot of different aspects of your metabolic health, not just, your LDL cholesterol is this, so this.
So let's define that. So we use that term a lot, metabolic health and metabolic syndrome. Will you just define that for us?
So metabolism overall is how your body uses food and the building blocks of proteins, fats, carbohydrates to make energy. And so metabolic syndrome happens when, for complicated reasons, our body, it does not do so well with using those building blocks appropriately, and they get stored in unhealthy ways. And so, metabolic syndrome has multiple components, but it's an elevated blood pressure, an elevated triglycerides, elevated blood sugar, low HDL cholesterol, and an elevated waist circumference. And those, having at least 3 of those will constitute metabolic syndrome.
Hey there, listeners. Just a quick break to tell you about something that could make a big difference in your life or the life of a woman you care about. Here at Uplift for Her, we specialize in integrative women's health, offering comprehensive support for every stage of life. Whether you're navigating menopause and need expert HRT advice, looking to shed those stubborn pounds, or seeking for help with your mental well-being, we've got you covered. We combine the best of traditional and functional medicine with personalized health coaching and dietitian support here at our Salt Lake City-based clinic. We ensure that your unique needs are met with the care and expertise you deserve. At Uplift for Her, we're here to help you feel your best inside and out. Ready to take the next step in your health journey? Visit us at upliftforher.com or give us a call today. We have services available for those of you living in the state of Utah and some services available for those of you outside of Utah. Now let's get back to the episode. So that constellation of findings in a human has been shown to increase the risk for cardiovascular disease and other disease states. So when we talk about metabolic health or metabolic syndrome, we're talking about, like you just said, the way that the body takes in energy, breaks down that energy, stores that energy for right or for wrong, and then whether that promotes inflammation and promotes balance in the body or whether it throws the body out of balance. So that's what we're talking about when we say metabolic health. So how should this look in a perfect system? How should a good cardiovascular risk prevention routine look for a woman? What age would she start having screening? What types of screening? And how would that change throughout her life, her reproductive life, and so on? That's going to be a long answer.
Yeah.
But walk us through what that looks like in a woman's life in a perfect world, help monitor for cardiovascular health?
Yeah. So blood pressure should be checked every time we go to the doctor.
No matter what age.
No matter what age.
Yeah.
And so, you should get your yearly checkup, and your blood pressure should be checked there. As soon as we're around 20, we should be screened. And I think in pediatric literature, probably I won't speak to, but talking about women once they're about 20, we should screen everybody with a lipid panel, and then an A1C, which is the marker for diabetes.
And just to plug there, because so many people are going to their gynecologists, I don't know that it should be standard of care. I don't know that all gynecologists are routinely screening for a lipid panel and a hemoglobin A1C. I think it's perfectly appropriate to say, can you check my lipid panel and my hemoglobin A1C?
Absolutely.
I think that should be, if your gynecologists, I will say some of them push back and say, I'm not a primary care doctor. You need to go to your primary care doctor. You've got to deal with that as it comes. I think it's really appropriate to say, will you order these blood tests? And if they're abnormal, I will go to my primary care doctor or go to your primary care doctor. But that is perfectly appropriate to ask. Oftentimes, gynecologists, OBGYNs, bless their hearts, oftentimes we are very, very busy and inappropriately, sometimes our focus can turn towards the pregnant mamas, right? And it's not inappropriate, but we should care about all of our patients. Yeah. And it's really appropriate if they're rushing out the room to be like, hey, could I get my yearly screening labs? I know I'm supposed to have my cholesterol and my blood sugar. Yeah. That should be really easy for all of them to do.
Yeah.
And insurance pays for it.
Yes. Yeah, absolutely. So,
always.
Yes. And the other kind of more advanced lipids that are coming around can be considered as well. So I think definitely like an A1C and a lipid panel, everybody should get. But something called like an LP little a, lipoprotein little a. European guidelines now recommend that everybody gets that once in their life as well. Here, I think it's more for the high risk individuals, but say you do have, family history where people have had heart attacks in your family in their 40s and 50s. It's something to talk about with your doctor. That I could understand a gynecologist or OB maybe saying, go to a primary care cardiologist. Yeah,
if they don't know how to interpret it.
But there is some there is data that might be a good thing to look at, because we will have, it's a very strong enhancer of risk. And so it might make us take other kind of small changes in what we see in your blood pressure and your cholesterol. It might make us start treatment a little earlier.
And I've seen some recommendations for the LP little a to have it once in your premenopausal life and then once in your postmenopausal life. Is that what you recommend for women?
Yeah, for women I do. And then other thing I'll say that's female specific that I'm kind of just learning about is that actually your lipid panel will change during your menstrual cycle. Mm-hmm. And so having that in mind, it's a small change. So if you're just getting screened and it comes back pretty normal, that doesn't mean you need to check again. But for somebody who we're treating for, something like a familial hypercholesterolemia or has had a heart attack, we're really trying to be aggressive and get a target. You might just take note of that and do a couple throughout, like at different points in the cycle, just kind of know where you're at.
Yeah, I think that, or just comparing apples to apples. Like if you get it done at the first part of your cycle, always get it done at the first part of your cycle.
Yeah.
It's not always very easy, but yeah. And if you're on a birth control pill or you're on a, IUD and you don't know, just wing it. It doesn't change it too much, but it is interesting to see how much it can affect it. And I think, like you're saying, when it matters for treatment, then you can coordinate that.
And then so going back to kind of the like stages of a woman's life. So they're going to re-engage with the healthcare system around if they are going to become pregnant. Always a good time to recheck your blood pressure. I know you guys do screening for diabetes at that stage. Checking a lipid panel during pregnancy is probably not necessary. And
in fact, it will be abnormal.
It will be very abnormal. Yeah. And it's not going to guide us one way or another. But the next point that, you would want to continue to get your routine care, get your blood pressure checked. And then after menopause, your cholesterol levels can change hugely because of the change in hormones. So, the traditional, protective effects of estrogen that we talk about, change during menopause. So that's really important to not be surprised that all of a sudden your cholesterol is high and it was fine your whole life. Mm-hmm. It's not your fault. It's just it's normal. It's going to happen.
You mentioned earlier the waist circumference. That's not something, I don't think it's done at most clinics, including mine actually. And I believe it. And I honestly just don't, there's just a lot of things and you don't do it. So that is definitely something that people can track themselves, especially if you're starting to worry about risk factors there. Some people do a waist circumference, some people say waist hip ratio, but both of those can be helpful. So let's take sort of a little branch away here. Talk about pregnancy specifically. Mm-hmm. Let's maybe first talk about, as we're leading into pregnancy, what do we do if we are already at increased risk of cardiovascular health? You mentioned that a lot of people are pretty nervous to use statins, and a lot of people, I think it's easy to be like, well, you're so young. So your cholesterol's a little bit high. We'll deal with it later, right? Tell us about your approach to that pre-pregnancy cardiovascular risk for those who are at risk.
Yeah. So I think we should just recognize that, we just mentioned this protective effect of estrogen when it comes to the atherosclerotic, like speed bump disease. That goes away in patients who have diabetes or patients who have familial hypercholesterolemia. So then their risk becomes the same as their male counterparts. So that's really important to know. And so they should be treated exactly the same. And we say the protective effects of estrogen also, it just means that if you don't have these increased risks, you still have that risk. You're just about 10 years behind a male counterpart. So the risk is still there. It's just a little bit delayed. However,
so you're saying, so for people who are diagnosed with familial high cholesterol, then they should be treated before pregnancy.
Yes. So my approach. So, familial hypercholesterolemia can be diagnosed in childhood and often is. So I guess we can kind of take an aside there and talk about that. So familial hypercholesterolemia is a genetic disorder.
How common is it?
It's very common. Yeah. It's about 1 in 250 people. Yeah. Mm-hmm. So very common. It's autosomal dominant. So 50% chance that if your parents have it, you will have it. And it's basically, our bodies are really good at kind of recycling cholesterol and grabbing it from the bloodstream so it can be used for other purposes. People who have this genetic problem are missing some of those receptors. And so the body just can't grab the cholesterol out of the blood. So it sits in the blood and causes the problems we've been talking about. Luckily, if it's treated, your risk kind of goes back to baseline. So as long as you're on treatment for this disease, you can really prevent a lot of the downstream issues.
And that's usually diagnosed to start with just with a lipid panel in childhood or teens.
Yes.
Typically.
Mm-hmm. So that's why I say a lipid panel is so important. And I would have a pediatrician guide when in childhood it should be done, because during puberty, there's going to be changes too. But it's
usually pretty obvious though.
Yeah. Mm-hmm. Yeah. So but that's one of the things that we're looking for with screening with a lipid panel. That's huge. Is just make sure that this patient doesn't have this kind of genetic problem. And if we do see, usually it's defined by an LDL cholesterol that's greater than 190 milligrams per deciliter and a family history. I recommend genetic testing for patients if they're interested, but I always send them to a genetic counselor so they can talk about, what that really means. But when this is diagnosed, and usually it's diagnosed young, women are often undertreated because of this pregnancy consideration. So statins were previously category X by the FDA for pregnancy. That has been removed as of 4 or 5 years, 2019, I believe. So, which is great because
that meant before that it was considered, in my training, we said, you cannot under any circumstances take a statin during pregnancy because it will cause a birth defect.
Right. And now we have, we don't have great data, but we have some data that it's not causing birth defects. Mm-hmm. So I think because when a drug is category X, people are really afraid to prescribe it to anybody with reproductive potential, which is not right.
Right.
I think if you are actively considering conceiving, that is when you can have a conversation about maybe stopping the drug or kind of how high risk you are and go through it with, a cardiologist or an OB who's comfortable with that. But if you have just because you're 20 doesn't mean you shouldn't be on a statin because this was a previously considered, a potentially harmful drug, because it's probably not. And it's even safe to be prescribed in children. So we know that this is a pretty safe medication.
And I think also there was the thinking of like, well, you're 20 and you might have a baby in like 8 years. So why would we bother? Because we don't want to start it and then stop it. And the fact is that if you're 20 and you have high cholesterol, number one, that's different than a 60-year-old who has a little bit of elevation in cholesterol, right? Like you've got 80 years potentially to run around with potentially a big problem. Yeah. So we have to look at this at a more macro view and say, okay, you've got a lot of years. Mm-hmm. How do we do this? And that does take, you may need to advocate for yourself and say, I want to have a bigger conversation about this. It's okay to say like, can I see a cholesterol specialist? Can I see a cardiologist and really get my risks better? I do think in medicine, when you get to the specialist, like a cardiologist, they want to prevent that heart attack. They see heart attacks all day, every day. They want to prevent the heart attack. And I think it's easier for those of us more in the screening side of medicine it's easier for us to downplay it and be like, well, I don't see heart attacks in your age.
Yeah.
I just don't see that. So let's not worry about it. So just a plug to advocate for yourself and to recognize that we as women need changes in our healthcare that address before pregnancy and then during pregnancy and then after pregnancy and then after menopause. Like we can't have these sweeping, like, this is how you treat women because our bodies are going through these massive changes. So it's really okay to say, okay, I'm not pregnant. Let's do this thing. Let's optimize my health now.
Yeah.
And then to say, I'm planning to get pregnant. I should talk to a specialist, optimize it again. I'm now pregnant. Let's figure it out, do it. And then postpartum, do it again. So
yeah, no,
it may take your own advocacy though.
Absolutely. Yeah. And so I think that's just an important thing. And sorry, I think we didn't even clarify what medication I'm talking about when we're talking about familial
I think you said
hypercholesterol. Maybe
statins.
Statins are the kind of first treatment. And the good thing about statins is, that we've been around a long time. They're safe. But if people don't tolerate them, we have other options now as well.
Yeah. Okay, wonderful. Tell me about pregnancy conditions that we won't go into this too deeply, but pregnancy conditions that people should have, at least doctors should have on the top of their list, but that people should know, okay, this is worth knowing. This is not an isolated pregnancy thing, like morning sickness. You could argue, okay, like once you're not pregnant, don't worry about it. But for people who have certain issues during pregnancy, they need to know that changes their potential for problems outside of pregnancy. What are those conditions?
I think the one that's probably under-recognized the most is preeclampsia.
Yeah.
Because it doesn't have diabetes or hypertension in the name, but it is a vascular problem, a pretty complex vascular problem that you probably understand even better than I do. But it's a huge risk factor for developing hypertension and then subsequent heart attacks and heart disease.
Yeah. And I think along those lines, it's a weird disease and it's a massive spectrum. And so there's people that say, oh, I got preeclampsia at 37 weeks and they had to deliver me early. And then there's people who get preeclampsia at, 24 weeks or 30 weeks. I think that severity, we don't understand exactly why that severity is different, but the severity needs to be, you need to attend to it. And then I also think some people's blood pressure will just normalize within hours of birth. Yeah. That's good. There are some people who need blood pressure medications for a week or a month or 6 months after. And I think the higher the severity, the more you need to say like, okay, there's some underlying thing that made my body vulnerable to this severe situation.
So that's one I think like you should, if you were just talking to a cardiologist for the first time and they didn't ask about your OB history, bring that up, bring up gestational diabetes and bring up hypertension during pregnancy, even if it was just isolated during pregnancy.
Or before.
For
sure.
Yeah. And then the other thing that I think is we talk a lot when we see women who have known cardiovascular disease, say congenital disease or otherwise, is something called like the fourth trimester. So after a woman gives birth, there are still a ton of hormonal changes and fluid shifts and all these things that are happening so if you had a complication right after your pregnancy and, maybe you didn't categorize that as a pregnancy complication, but you were in the hospital for any reason after the pregnancy, I would definitely bring that up. Mm-hmm. That's an important thing for your cardiologist to know.
Mm-hmm. Mm-hmm. Is it worth commenting just about why pregnancy, like pregnancy in the heart? Like why does that expose vulnerability? So maybe it's the easiest way to say it. Do you want to comment on that?
Yeah, it's a huge topic.
Yeah.
So your blood volume massively expands during pregnancy. And so the things, we worry about a lot are obviously the lumpy bumpy disease if it's caused any problems with the heart pumping function. But, we haven't talked as much about the actual diseases just of the muscle themselves, but there are problems with the heart muscle. There's a lot more demand on the heart during pregnancy. There's issues with the heart valves. There's a lot more demand on those during pregnancy. And then, your blood pressure should go down during pregnancy because of this expanded volume, your vessels should relax. And so if you have a predisposition to not allowing those blood vessels to relax, and then the volume expands, that was the definition of the two things that contribute to high blood pressure. Obviously that's putting double the pressure on those vessels that already have an issue. And so it's just a huge change in your physiology. And it's obviously going to affect all your organs, but your heart has to accommodate all that extra volume.
I just want to pause for a second and bring it back to, I don't want this to be too much of a downer. It is a bummer talking about the body, the way the body doesn't work.
Yeah.
But I think if we went back in time and just saw people like dying for no reason and like, what happened?
Yeah.
Like that person was alive and then they died. Like what happened? And now we have so many risk factors. We have so many things that can help us understand and empower us as individuals to say, okay, my family member had heart disease, or my family member, my dad had a heart attack when he was, 50, or I have 8 family members who have had heart disease, or I have had cholesterol for a long time, or I have had high blood pressure. Those are tools that we get to use to say, okay, well, let's take care of me. Let's figure out how to best live for me. Now, the end of this conversation is we really all should be doing all the things. We should just be eating a diet that's healthy for our blood sugar and avoiding, smoking. And we should all be doing these things. But once you start spotting these risk factors, it is like early warning, right? We get these early warning signs of body's not happy. You better change something because the body's not happy with it. We get to do that. And that can be annoying because we wish that it wouldn't. But it is also empowering. So I hope it's not a downer. I hope people will feel like, okay, now I know. Now I know, like I had preeclampsia. I've struggled with blood pressure off and on. Every time I go to the doctor, they tell me my blood pressure's high. You gotta know that. You want to address that because that's a sign that your body is feeling some wear and tear or feeling some struggle to do its regular daily activities. And that's the time that we want to start, even if it's a medication, even if it's lifestyle change, like get the help that you need so that you don't have that issue pile up over time.
Yeah. And we can kind of take you through in the clinic too. Once we have identified that there is some risk factor, we can kind of lay out what that means in terms of even numbers. We have risk scores that can do that. And then we can see when your blood pressure comes down with either a lifestyle change or medication, usually both, we went from a higher risk situation to a lower risk. So that can be really empowering too, to just, I think, not be down on yourself when these kinds of diagnoses come up, because being hard on yourself is just going to make it harder to do the next step that needs to happen. And then when you do the next step and you see that it's working, it can be really gratifying. So that's knowing that you do have control over a lot of these situations should be empowering.
Yeah. Wonderful. Tell me a little bit more about some screening tools that people will have heard of. You think about an EKG, a stress test, an echocardiogram, and one that people may not hear as much about is the coronary calcium score. At what point should those come into play for women?
The calcium score is one that I think is very useful. Unfortunately, and I can kind of explain what a calcium score is. We talked about the speed bumps. I love this analogy, obviously. I keep using it. And we talked about how your body's response to the cholesterol getting into the blood vessel wall is to kind of send the immune system to neutralize it. The result of that immune system kind of walling it off is literally creating some calcium there. And so the calcium shows us that your body has recognized there's cholesterol there and is walling it off. So it's an indirect marker of cholesterol in the artery. But if it's fluctuating, going up and down, it could just mean that you're kind of are doing what we call like positive remodeling. So you're making healing the cholesterol situation. So focusing a ton on the number is somewhat helpful, but really it's just, is it there or is it not there?
Yeah, 0 or non-zero.
0 or non-zero. When it gets really high, we talk about other tests. But when it's, somewhere between 0 and 300-ish, we kind of just say, okay, we know that the cholesterol is being pesky, we should lower it. And so that's when I use a calcium score is when I'm considering starting the cholesterol medication, and it kind of helps us make that decision. So I wouldn't call it a screening test. I would call it a decision aid. And that's when it's really helpful. Unfortunately, the calcium is a slow process for that to happen. And so people under 40, it's pretty unlikely for them to have any calcium buildup. So it's not a useful test in younger people unless they're very high risk.
So just to go back, it's a CAT scan of the vessels of the heart, and it's looking for calcium buildup. So it's a coronary calcium score. So it's looking for calcium buildup in the vessels supplying the muscle. And if there's calcium there, then that means there's some plaque there, mostly, unless it's remodeling, but pretty much. Yeah, pretty much. That means there's plaque there. And that means that it tells you already have some amount of cardiovascular disease state. So that can be helpful, but not too young because it takes a while for the calcium to actually build up. Go back, because you mentioned this a couple times, the unstable versus stable plaques. Tell us more.
This is kind of comes into play a bit more when we know somebody has a lot of those lumpy, bumpy, and disease. If you, and they can, it's so severe that the blood vessels are kind of constantly not getting enough blood flow. And so when they do exercise, they get chest pain all the time. If that chest pain is kind of constant, we treat it with medications called stable disease. If it's unstable, that means it came out of the blue. It's much worse than it's ever been before. And you're really concerned. That's probably unstable plaque. So that means it ruptured. How do we identify that early? That's what we need to figure out in cardiology. So we have more invasive tests where we can do, give you contrast and slow your heart rate down and take really good pictures and try to figure out which plaques are the bad ones and which ones are the good ones. The dye is going
through the vessel.
Yeah, where the dye goes through the vessels. And I think that's kind of the frontier. That's where we will be in the future for screening. But right now, that's a bit of an invasive test. So it's radiation. People can have allergies to the dye agent. And we need more data to know that it's helpful. But if you're having chest pain, we're trying to figure out why. It's a great test. If you don't have any symptoms, but we're just concerned something might be there, we're not quite to the point of using that. Mm-hmm. We are using the calcium scores for people who we just want to see if there's anything there, because it's a quick, no contrast, so no dye. It's very low radiation dose. It's pretty inexpensive. Not a lot of kind of incidental findings, although there can be some, which we can talk about too, and why we don't just scan everybody's whole body all the time.
Yeah, right.
But that is kind of what I'll say about screening is I think in the future in select patients, we will be able to look at those plaques really closely. We're not quite there yet.
What about a yearly EKG?
The U.S. Preventive Task Force doesn't say that we need that. There's insufficient data. I don't think it's a bad idea. It's another one of those non-invasive, cheap tests that can give you some information. But any kind of testing can cascade into more unnecessary testing. And so there can be a lot of abnormalities on EKG that are not concerning, but often it can lead to an echocardiogram and kind of more medicalization of normal, healthy people.
Yeah. I want people to have an idea of my doctor didn't order that for me. I think that's okay.
Yeah.
I think just a reminder as we kind of talk about this, that the cardiovascular disease is best viewed from the macro level. It's best viewed from, we're looking at all of these factors, and some people are going to have more of factor A and less of factor D. And some people are going to have tons of factor D and none of A. And some are going to have A, B, C, and D, right? You want to look at those people can all end up with the same disease state. So what we're looking at is we're looking for all of the things that factor in, and how do we minimize the lowest hanging fruit, the ones that are easiest to minimize, like cessation of smoking, right? That's an easy one. You should stop smoking. Yeah. Some of them are harder, like genetics. So we're kind of looking at all of these pieces that contribute and say, could we lower this one a little? Could we lower this one a little? So if a woman has, I think we'd be remiss if we don't talk about the presentation of heart disease in women compared to men. Mm-hmm. All over the warning posters in hospitals, it'll always say chest pain and left-sided arm pain, right? Tell us what the difference is with women.
So often women will present with GI, so gastrointestinal symptoms, so nausea, vomiting, sometimes anxiety, things like that can be ignored. And so that's a big problem. And so obviously, if you having these new acute symptoms and you're very concerned, asking for an EKG is not unreasonable.
And should it show up on an EKG?
If it's an acute heart attack, almost always. There are, depending on the severity of the heart attack and the location.
So to put that in perspective, because we don't want to create a bunch of panic in women every time they have a stomach ache, right? Yeah. I think the first step is to say, what is your underlying risk, right? Mm-hmm. Are you overweight? Do you have high blood pressure and your doctor told you to take a statin and you're not taking it, so your cholesterol is high? You should have a higher threshold for paying attention to weird symptoms. Is that anything you want to add to that?
Yeah, I think also kind of if you have uncontrolled inflammatory disease, I've seen that more commonly in people who don't have other risk factors, but that should be on your radar too.
And so then how does a woman tell a difference? If she has these high risk factors, she's going to be more apt to pay attention. Mm-hmm. But I think one of the keys to these symptoms is they should kind of be coming out of the blue and or related to exertion. Is there anything you would say to clarify that?
These symptoms are caused by not enough blood flow getting to an area of the heart. So that can be because you've just done something that kind of made your heart work a little bit harder. And so then the blood flow doesn't get there, or all of a sudden the blood flow stops without you working hard. So it can come out of the blue. And typically it's going to be something that lasts 30 minutes, and it's going to be something pretty concerning, the symptoms. But
so it's not just going to be a little tummy ache.
Yeah.
Yeah.
And then, but if it is coming with exertion, sometimes after a large meal, and then sometimes with stress, it should be the kind of thing that comes on and gets better if you rest, or if that kind of goes away. So, constant pain for multiple days should be evaluated, but it's usually more periodic.
Yeah. And you hate to say this too much, but I do, again, with advocacy, I do think it's missed a lot. So if you feel like, I'm really worried, I think something could be wrong, and you go to the ER and they say, well, take some Imodium or something, I think it's okay to say, would you mind doing an EKG? I say this sensitively because it's a complicated thing, right? You go to the hospital and they say, like, stop telling me how to do my job. But I think by way of advocating for, if you have done your research, you've listened to this, you're at high risk for a heart attack, you're having symptoms that are really concerning out of the blue. An EKG is not that big of a deal. They can do an EKG. Like, if you're there, they can do it.
Yeah.
So it's okay to kind of push and be like, can you rule out a heart attack? Because I've heard that these symptoms can, be different in women. And they might glare at you, they might be rude, but like, get the EKG and call it good. And then if it's normal, then you can go home knowing, like, maybe it is heartburn. Yeah. That's fine.
And if they did a blood test too, if they do look for heart damage in the blood, and especially if they check it twice, really, really, really sensitive test for ruling out an acute heart attack. Doesn't mean that there wasn't an episode of low blood flow to the heart that kind of recovered and could come back. So I don't want to completely dismiss people who come in and get negative, what we call troponins, or negative blood work. That doesn't mean they don't warrant further workup, but it does mean you can probably go home and get it with your cardiologist in the office.
And if you're having a somewhat new symptom that's coming with exertion, then that's something.
Yeah, I would definitely need to work that out.
Talk to your primary care, especially if you know that you have high cholesterol, you have high blood pressure. Pay attention to that. This is why. I mean, to be fair, like, this is why it's missed all the time, is because it's not a super obvious thing. I mean, if blood is coming out of your arm, then it's easier to be like, well, I know what that is, right?
Yeah.
I think when you have these vague symptoms, you don't want to make every woman who has a symptom feel like she's having a heart attack, but it sure makes it hard to differentiate, like, who's the one who's having a heart attack and who's the one who's not. So that's why it's empowering to women to, I mean, I talk about this all the time, but like, be in tune with your body, understand your body, know where you're at in your cycle, know your risk factors, know your blood work, know your, educate yourself, because you will take better care of yourself, and you will help your doctors take better care of you if you know these things.
Yeah, absolutely. It's really important. And I think, but it's also good to know that, if you cut yourself, you have a lot of nerves. You can know exactly where that happens.
Yes.
And you're inside your
all little
body.
Vague.
It's just a whole different nervous system. So it's really can be very hard to locate. There can be referred pain. It's a whole different kind of mind-body connection when it comes to our internal organs. So that's why it can be really tricky.
And if you go to the ER, they may be thinking, oh, your lungs, do you have wheezing? Yeah. Do you have pneumonia? Like, it's okay to be like, could you check my heart?
Yeah.
I think that's okay. Okay. We're just in the last couple minutes here. And we haven't covered nearly of what I wanted to cover, because I really wanted to cover a lot of the prevention and the lifestyle. So we'll talk about the lifestyle and the prevention another time. But will you help us just understand, as the last question, help us understand a lipid panel?
Yeah.
Because you said we should go get a lipid panel. What does that mean?
So we kind of talked about the building blocks of, what we take from our food and use to make energy. Lipids are one of those chunks. So we talk about like fats, proteins, and carbohydrates. Fats are what we measure on the lipid panel, and they're what's kind of in the blood at any given moment. But I think what I wanted to kind of emphasize is that there's two big categories of lipids that we're looking at on the lipid panel. One is your cholesterol, and the other is your triglycerides. And triglycerides are different than cholesterol in a big way. So cholesterol has kind of more of a structure, and it's used for making hormones, and it's used for making cell walls. Triglycerides are really great sources of energy. And so your triglycerides right after you eat are basically, most of the fat in your food will end up being triglycerides in your bloodstream, and your body will take those and use them. Your muscles use them for energy, your brain, like, they're just great energy sources. And then the cholesterol is kind of stored away and used for very specialized purposes. And usually it's neutral, as long as it's not too high and getting into the blood vessels. When you're looking at your lipid panel, kind of in your mind, just kind of separate those two things and think about the cholesterol levels, and then think about the triglyceride levels Triglycerides have more to do with your diet and your metabolic health and your cholesterol blood sugar. Yeah. And your insulin resistance. Where if your cholesterol is high, kind of that often is genetic, especially if it's very high, and it's a little bit harder. It's not impossible, but it is harder to control with diet and often requires, if it's very high, medication. But the biggest thing I think I talk about in clinic all the time with my patients, because, I'm going to do a lot of lipid consultation. And I'm just going through their lipid panel, I think everyone's heard LDL cholesterol is the one that we should worry the most about. If your triglycerides are high, a typical lipid panel uses the triglycerides to calculate your LDL. So it's not directly measured. So that LDL level in your lipid panel is not really what you want to look at if you have high triglycerides.
Meaning over
150, and especially if they're in like the hundreds. So then you just kind of look right down. It's usually right underneath the LDL. There's something called the non-HDL cholesterol. And I think we've heard a lot about HDL cholesterol being kind of this good cholesterol. It's basically just it's probably not neutral. It's just not bad cholesterol. We want it to be higher. It's bad when it's low. But anyway, so taking a look down there and just knowing that that's kind of another thing that you and your doctor should be paying attention to is that LDL cholesterol is one data point, but that non-HDL cholesterol is probably a more important data point in predicting kind of how much of your cholesterol is like the problematic kind.
So let's go through that really quick, because one of the things I hear most from my patients is, thank you for going through my labs with me. Because usually I just get an email that says it's normal or abnormal. So let's let people go through it. Get a pen.
Yeah.
So total cholesterol is usually at the top, and total cholesterol we're aiming for.
Yeah. I mean, it really depends on the person. Less than 200 would probably be
generally less than 200. And then usually triglycerides are right after that. And triglycerides less than 150.
Less than 150.
Less than 100 would be great.
Yeah. And it does depend on if you're fasting or not.
Yep.
So I don't make my patients get fasting lipid panels, but if we have a triglyceride issue, I do.
So nice. I do.
I do, because I just want to know kind of what's going on a day-to-day, because the triglycerides, if they're really high and they're not fasting, it tells me something.
Yeah.
But so under 150 is considered kind of goal if we're looking to lower triglycerides.
And then HDL greater than 40 typically is considered protective or neutral.
Yeah.
And then LDL, is it same for non-LDL, is still the same target of?
I add 30 to the non-LDL to LDL to get your target for your so if your LDL goal is like under 100, your non-HDL would be less than 130.
And these are usually on the lab. So if someone gets their own labs, they're usually there, except I find the LDL ranges are all over the place. A lot of them will say less than 130 still. And I usually tell them less than 100. Is that what you're aiming for?
I mean, it really, I like to tailor your LDL goal or your non-HDL goal to the person. Yeah. But if we're talking about risk and cholesterol,
just as a general screen,
we do like it, somewhere around 100 or less. And then if you've already had an event or you're high risk, lower is better.
Different story. Yeah. And then Lp(a), you're aiming for?
Yeah, that one, it depends on if it's millimoles per deciliter or milligrams. But it becomes a risk factor when it's in the like 60s or higher for milligrams per deciliter. And that's above normal, but like there's a kind of a gray area with Lp(a). We don't have targets for Lp(a) yet because we don't have anything targeting it yet.
There's
but
nothing
we will
to lower
soon.
It really.
Yeah.
And then for hemoglobin A1C, that's the diabetes marker, and that lab range is usually correct on there. Less than 5.6 is considered less than prediabetes, so 5.6 and above is prediabetes. I like 5.4 and below personally, but I get a little picky with it. Anything else? Any last final words of like shout it from the mountaintops to women for their heart health? Anything that you want to end with?
Oh yeah. I mean, I think we were kind of talking about this before we went live, but don't be too hard on yourself because I think,
there's so many factors.
There's so many factors, and a lot of things you can control and work with your doctor, find somebody who you like and trust. And, but you can't make positive changes if you're feeling bad. So,
and this is what you and I were talking about is even knowing all of this and being around all of this, it's still really hard to do all the things. So we do our best.
We just do our best.
Fortunately, we have medications and medical support to help us sort of hopefully make up the difference where possible.
Yeah, absolutely.
Awesome. Well, hopefully we'll have you back because we still want to talk about menopause and hormonal changes with heart disease and a couple other things. So thank you so much for being here.
Yeah, thanks for having me.
Thank you so much for tuning in to today's episode. A huge thank you to our guest for sharing their insights and time with us. We are grateful for the incredible support from our sponsors and to all of you listening. We couldn't do this without you. If you enjoyed this episode, please consider subscribing on your favorite platform. You can find us on our website, upliftforher.com, YouTube, Apple Podcasts, Spotify, or wherever you love to listen. And if you found value here today, please share this episode with someone who would benefit from it. Leave us a comment or give us a review. It really helps us reach more listeners like you. Thank you for being part of our community. Stay tuned for our next episode. This information is for educational purposes only and not intended to be medical advice.